Good afternoon, distinguished guests, faculty members, and resident doctors, ladies and gentlemen. I'm Dr. Javaria Younas, working as Assistant Professor of Neonatology at University of Child Health Sciences, the Children's Hospital, Lahore. And I welcome you to this workshop on peripheral insertion of central venous catheter, prevention of central line-associated bloodstream infections, and use of ultrasound in identification and placement of central lines. We are privileged to have our Honorable Chief Guest, Professor Samia Naimullah. She is former Head of Department and Professor at Rifa Medical University, Rawalpindi Medical University. She received Best University Teachers Award by Higher Education Commission of Pakistan and President's Gold Medal Award by Pakistan Pediatric Association for her outstanding services for child health and academics. She is also convener and examiner for all the medical examinations from MBBS to fellowship programs and MD programs. I invite our first speaker, Professor Khwaja Irfan Waheed, Professor of Neonatology, who did his fellowship in neonatology from UK and has outstanding contribution towards improving neonatal morbidity and mortality in the country. He will enlighten us with the technique for peripheral insertion of central venous catheter.
Yes, assalamu alaikum, ladies and gentlemen. My presentation is about how to insert a long line, and which is also called percutaneous central venous insertion, central venous catheter insertion, sorry. Acha ji, let me start. I hope that all of you are concerned with neonatology and are using long lines. There are different modes to access central vessels. My mind is a bit slow because of being tired and post lunch, but I will try to catch up. So there are different modes for central vascular access. Vascular means both arteries and veins, which I call them as lifelines in neonates. They are actually lifelines. If we are able to secure these lines, it's likely that we may be able to save a sick child. If we put them in artery in a newborn, that's called umbilical artery catheterization. And there are two modes to put up a central line, central venous line. One is umbilical vein catheterization, and second is percutaneous central venous catheterization. So two modes for venous and one mode for central arterial catheterization. The purpose of today's presentation is to present about central venous catheterization. It is also known as peripherally inserted central catheter, PIC line. It's also called a long line because it is inserted from the periphery, and through the peripheral veins, it is threaded into a central vein, which is inferior vena cava. The primary indications for insertion, the scheme of my presentation is I will first give this presentation, and then there will be a demonstration by Dr. Usman Khalid and Ms. Sonia Anwar, which will they will actually show you how to put up a long line in mannequin. The primary indications for insertion of a central venous line is that it is used for total parenteral nutrition. It is also it can also be used for a long-term intravenous medication, long-term, not short-term. It is also used for giving hyperosmolar intravenous fluids. For example, may I ask any example of hyperosmolar fluid? GIR, the glucose infusion rate. Precise word use karo beta. High concentration of glucose. That's what you want to say, not infusion rate. Any other example? Hypertonic sodium. No. बेटे कोई और चीज ऐसी सोचो कि जिसको आप पेरिफेरल इंट्रावीनस लाइन से दो, अव्वल तो बाहर देने की कोशिश करोगे, वो नहीं देने देंगे. Bicarbonate, yes, that's hyperosmolar, about 10 times more osmolarity. आपने दूसरा ग्लूकोज का कहा, yes, more than about 12.5% dextrose that should be given through a central line. बिल्कुल ठीक कहा बेटा आपने. And what about calcium?
Calcium infusion.
अगर आप कैल्शियम को देने की कोशिश करेंगे पेरिफेरल इंट्रावीनस लाइन से,
Calcium
शायद
chloride.
फॉरेन कंट्री में कोई आपको देने नहीं देगा, कोई नर्स नहीं देगी, वो सेंट्रल डालना पड़ता है या फिर बहुत ज्यादा डाइल्यूट करना पड़ता है. तो ठीक है बेटा. सो हाइपर ऑस्मोलर इंट्रावीनस फ्लूइड्स के लिए या इरिटेटिंग आईवी मेडिकेशन. इरिटेटिंग आईवी मेडिकेशन अगेन आर द सेम which are basically hyperosmolar. So the purpose of putting up a long line is to use either TPN or hyperosmolar fluids. Secondary indications, which are not that important, are repetitive blood sampling. Please note that long line is not to be put in just for the sake of blood sampling, but in case if it is you need to draw it a blood sample and you don't have any other access, yes, then you can use a long line, but you have to be very careful in opening what we call is breaking the line. And for short-term medication, if there is a medication that has to be given and you don't have any other venous access, then you can use it, but with extreme caution, because breaking the line, what we call breaking line means opening the line. It has to be done very carefully, observing all the antiseptic maneuvers. Where we cannot put up a long line is, although there are no absolute contraindications, but relative contraindications are if there is an infection at the site of insertion, you will not put it there. Or if there is ongoing bacterial or fungal bacteremia or septicemia, again, you will not be able to, you should not put up a long line, because once these bacteria or fungi, they seed a long line, it's very difficult to get rid of them. Uncorrected bleeding diathesis, again, is not an absolute contraindication, it's a relative contraindication. In minor bleeding diathesis, you can put up a peripheral long line, but if it's absolutely necessary. And if you have a peripheral IV access where you can use it for management of newborn, you may not put up a long line. It's a tedious process, probably one of the most technical maneuver in newborn, different types of newborn procedures. If you don't have supporting equipment or specially trained nurses, don't try to put up a long line. If you don't have a proper nurse to look after it, rest assured, even after you have put up a long line, it's not going to work. Somehow there will be a problem, either infective problems or clogging or whatever, and it will be wasted. It's an expensive piece of equipment, and must not use it without specially trained nurses. Certain precautions that need to be taken care of. You must have trained personnel, get consent forms signed before putting up a long line. You must anticipate. Anticipation means that if you have to put up a long line, for example, an extremely preterm baby is born and you have already planned to put up a long line after the birth of that baby, please do not prick those veins which are used for, generally used for insertion of long line, because they are better lines. So there is a tendency to put up a cannula there. And once those lines are used up, you won't be able to put a long line there. So anticipation is extremely important. Sterile technique must be used. Cardiorespiratory monitoring is done. After a long line is put in, we must confirm the position. And after the long line is put in, we will not handle it without any real indication. They are better left alone. The veins that are used for central venous access in upper limbs, either upper limbs are used or head and neck or lower limb. are basilic, cephalic, and median cubital vein. The easiest one is right basilic vein. It is straight. Basilic one is straight, right basilic. The cephalic vein, because it dips in the deltopectoral groove, so sometimes it kinks there. And others are axillary, because axillary is very near to the neurovascular bundle. So we better avoid it, but in extreme circumstances, we can use it. In lower limbs, great saphenous vein is used, but uncommon site is femoral. Although femoral is bigger, but it is very near to the neurovascular bundle, and there is a risk of damage to nerve or artery at that. Other veins which are used for central venous access are in the head and neck. Thank you very much. Commonly, superficial temporal vein is used, this one, but other scalp veins can also be used, like in common facial external or internal jugular. But while putting up a long line or while pricking a vein in the head and neck, we must be very careful that the head should be at a level which is below the heart. Otherwise, if the heart is above, if the head is above the level of the heart, and we put up a cannula, it can suck air in. So we have to be very careful in maintaining the posture while putting up a long line through the head. Where should be the tip of that catheter? Very easy. It should not be inside the heart. It should be at the junction of vena cava and right atrium. This is right atrium, and this is right upper vena cava, and this is inferior vena cava, and it should be at the junction of inferior vena cava, right atrium, or superior vena cava, and it should not be inside the atrium. If you can see, this is the right place. Okay. Let me introduce some of the materials in which this long line is available. It is available in either silicone or polyurethane. The advantages of silicone are it's soft, very soft, pliable, and it has a lower risk of perforation, and the chances of becoming clogged with thrombi is less as compared to polyurethane. But disadvantages are it is a little bit more difficult to insert as compared to polyurethane. Polyurethane is a little bit stiffer than this silicone. Silicone is very friable, and it is fragile. It is made of a friable material, and it can tear up if you put a lot of pressure. And higher pressure are exerted through a smaller size syringe, like 1 ml syringe, as compared to a bigger syringe like 10 ml syringe. And another disadvantage, it is less radio opaque as compared to polyurethane. How to choose an appropriate size of silicone catheter? If you see, there is a number given here. It is 24G 2FR size, and this is a number. If you see this number 015, is this the number? Right? And if you see, this is 15 centimeter in length. So if when we measure it, the required length of a long line, then we choose it. If we have to put it through foot, it will be roughly about 27, 28 centimeter. Then we will choose this 31, and before opening it, we will see the number. It should be 2184. So that's how we choose see the appropriate size. Second type of long line is made of polyurethane. The advantages are because of being a little more stiffer than silicone, it is easier to insert. It doesn't bend as easily as silicone, and it has a better tensile strength and is more resistant to pressure as compared to silicone, and is more radiopaque. But disadvantage is because it's being a little bit more stiff, the higher chances of rupture of a vessel. There are different types of insertion variants which are used. Breakaway needle. This is a breakaway needle. This one, after insertion through this needle, this breaks into two. And this is a peel away introducer. This is made of like polyurethane or plastic material. After we put up a long line through it, this just peels into two. comes into two halves. And there's an intact needle, and these are two different, intact needle, or this is intact cannula. When we use intact needle or cannula, then that type of long line is used, which the long line itself breaks into two. I will show you later on. Different techniques are used, percutaneous and surgical. Advantages of percutaneous are that it's simpler to perform, it's relatively rapid, no sedation is required, no ligation of the vessel, there are less chances of infection. But the disadvantages are that after initial insertion, further passage is totally blind, and you have to rely on either ultrasound or X-ray to confirm the position of the tip of long line. And being of smaller caliber, it is not suitable for blood transfusions. I'm not going to talk about surgical technique. Okay. So the type of equipment that is required are, some are non-sterile, but they can be sterile also. Mask, head cover, and tape measure. They are generally non-sterile, and we use them before we touch the long line and before we start the procedure. This is a list of equipment which is required. I believe I should not go into the detail of because it's a long one, it will take a long time. But I will stress on, this is called an octopus. The other instrument equipment which is used for diversifying or for multiple channeling is a three-way stopcock. We should not use three-way stopcock in newborns because of higher chances of infection associated with three-way stopcock. This is a totally sealed thing. It's called an octopus. It can be two-way, it can be three-way, or it can be multiple. Before we wash up, we give a baby analgesic, which is generally 24% sucrose, or commonly known as sweetie. 0.1 ml per kg. It is absorbed from the mouth, and it gives an instant relief from pain. The only pain the baby suffers through this procedure is the pain of prick of the needle, or baby becomes uncomfortable because of being held up. Wash your hands thoroughly, gather supplies, identify a proper vein before you put it in it should be a straight vein, and it should be in good condition. A vein that is already been pricked before, it's highly unlikely that you will be able to put up a long line, even if you put up a can line that's in that vein. Positioning of infant, we measure the length for insertion. If we are using an upper limb, the length is measured as from the site of insertion. I will show you in next couple of slides. Cardiopulmonary monitoring is done, and mask. This is how it is measured. If we use an upper limb, from the site of insertion along the path of the vein to sternoclavicular joint, and then down to the third intercostal space. That's the length of generally in the upper limb, it comes out to be about generally 9, 10, 11, 12 centimeter like that. And in that case, we will try to use a long line, which is about 15 centimeter long. If we use a lower limb, then from the planned site of insertion, whether it's near the knee or the ankle, along the venous pathway to the xiphoid process. And this is done before the baby is being cleaned for insertion. Then after measuring, after choosing the length of the vein, length of the catheter, we put up a sterile gown and 2 gloves. 2 gloves are easier to use as compared to changing the gloves later on. Then site is prepared, and after the site is prepared, means cleaning with either chlorhexidine or pyodine. Then the outer gloves, they are removed. Before you start handling the long line, these gloves should be fresh. So remove outer gloves after preparation of the site. Prepare the catheter means priming it with saline or heparinized solution. And in certain cases, like in Premicath, we can cut, it's 20 centimeter long. And if it, let's say we need to put 10 centimeter in, we can cut it at 12 or 13 centimeter, but it has to be documented in your logbook. It must be documented that this length of long line has been cut and thrown away. Because when we will take it out, we again measure it. And if it is again, if you put in 12 and take out 12, then it is safe. After that, we put up a tourniquet downstream, means above the vein, between the site of insertion and the heart. This is how we put up a tourniquet. This is how these all drapes are put in, and the baby's arm is taken out through an ear hole. After that, catheter insertion, we have cleaned this site here. Needle is inserted at 15 to 30 degrees from the skin. It has to be single good prick. If you have to maneuver the needle, rest assured this catheter is not going to go in. One clean prick. And when there is a free flow of blood and it gushes up fairly well, then that's the time when we loosen the tourniquet. And if we are using a needle with a stylet, then we remove the stylet and then we start threading in the long line by grabbing it with a non-toothed forceps. It has to be a non. If you will accidentally use a tooth forceps, it's going to puncture the long line. So non-tooth forceps is used like this. So we stabilize the needle and we will start threading this long line inside with a non. And once the long line has been inserted into the needle, please do not manipulate the needle because it can then damage the long line. Okay. Once this whole of the long line which is required is inserted, it is threaded in. You can see this is the site of insertion. Then we put up a thumb or on the long line, we stabilize it, and then we withdraw this needle. And after this needle is withdrawn, because this is a continuous needle and this is the type of a long line where it can be split into two. This is the hub. It is taken off and the needle is taken out. And then we can reattach this hub to the long line. But if there is a long line, which is a single piece, which does not have this breakaway system, then that type of this needle insertion is used where the needle breaks into two. After the needle is taken out, we temporarily secure the catheter with a steri strip. Steri strip is a sterile strip. Nothing will be brought into contact with the long line, which is non-sterile. So we just temporarily put it here. We cover it a gauze piece until the radiographic confirmation or ultrasonic confirmation of the tip of the long line. If the long line is in place, then we can proceed further. But if it is inserted a little more, we can take it out. And generally, we tend to insert a couple of centimeters more than the desired one so that we can withdraw it easily. But once the needle is taken off, we cannot then thread it in through the skin. These are different steps. If you can see, putting up a cannula, taking out the stylet, this is the plastic one, insertion of long line inside. Once the long line has gone in, we have taken off this peel away cannula. This is a single piece long line. Then this needle is split into two like this. After confirmation of the site, we clean this site of insertion. It is anchored with the skin using a sterile tape. And there are certain types of like silicone long lines which are not recommended to be cut. Then we then need to coil it in a circle, making sure that there is no kink in it. If this is a hub, this type of long line you use, that we put up a gauze piece between the skin and this hub just to prevent it pricking the baby, and so that the baby is comfortable. And then we fold this part over this hub like this, and then over that we put up a steri strip. All of the material that will come into contact with the long line is sterile. After initial stabilization, this is a sterile transparent dressing, and whole of this area is covered with that transparent dressing, and it is sealed like anything. There is no rent between sides, and it becomes like this. And but we take it into consideration that this transparent dressing should not go around the baby's arm. So otherwise there may be it may impede the venous circulation, and it may the hand may swell up later on. It should not go around the arm. This is how it finally looks. Look, this is that sterile dressing. This, and all of it is sealed, totally sealed. This is a needleless connector at the end of a long line. Needleless connector makes it us easy to attach and detach different fluids to the long line. Documentation after doing a procedure is extremely important, whether it is done supervised or unsupervised, site of insertion, number of breaks, length of catheter inserted, length of catheter cut, position, tip of the X-ray. It's very important because sometimes we need to follow it and sometimes the tip moves. So that we need to have a position at the time of insertion. How much was the time taken and different complications that were encountered during the procedure. For carrying the catheter, it has the site has to be examined frequently. Aseptic technique is used for change of tubing. Even if you are using a needleless connector, this does not mean that you can just put up any needle or any cannula and you, whenever you like, you can connect it or disconnect it. No, it doesn't happen like this. Whenever you will touch that hub, you have to wash up, fully scrub like you do it in surgery, and then you handle and this hubs, or break the line or make the line. No routine blood sampling. Small syringes need to be avoided because they insert a very high pressure. A constant infusion must be maintained, because if you will not maintain a continuous flow of fluid, there's a long line, there is a high probability that the blood will come in and it will clot, and once it clot inside a long line, come what you do, it's not going to work. You have to take off the line, and lines are precious. Maximum flow limit is maintained according to the manufacturer's advice. Haplock means heparin lock. Say, for example, for 10-15 days you have used a long line, and now you don't intend to use it further, but you will not take off the line on the same day. You will haplock it. Haplock is that you normally you use 0.5 to 1 unit of heparin per ml, but in haplock it is 10 units per ml, and 1 to 3 ml is flushed every 8 hours, and it is no fluid is given through the long line during that period. Observe it for a day, and if you need to resume using a long line, you can just attach a fluid and it will start working again. But if you have not haplocked it, you will not be able to use the line again. And after a day, if you don't need it, then the line can be taken off. Now, when we need to remove a catheter, The indications are when it's no longer required, or it becomes occluded, it's not working, or if there is a local infection or phlebitis or catheter colonization, then we need to remove it. If the baby becomes septic because of any reason, and it's not improving despite of giving antibiotics, then we need to take this line off. The procedure is, again, it's a sterile procedure. We need to clean the local site, maintain a gentle pull. If it is stuck, if it's not coming out, just flush it with saline and hot compresses, and hot compresses can be given primarily on the other limb also. If it gets broken, you must document the length which comes out. Ensure hemostasis, occlusive dressing for the prick site. Tip is sent for culture, but current and nowadays you may not send the tip for culture. Even the blood culture is enough, and the procedure needs to be documented. Different complications associated with long line are damage to the other vessels and organs, phlebitis, catheter migration, and malposition. If you see catheter being inserted from here and it's going up into the jugular rather than coming down. And if you can see a lot of catheter inserted, it is kinking inside the heart. And similarly, if you see this one, a catheter being inserted like this, and it has curled from here and is going to the other side. So the position needs to be confirmed at the time of insertion. Catheter-related sepsis is quite common. If you are not careful in handling, if you don't have a trained staff, it's likely that it will become infected, and once it is infected, it will not work. Thromboembolism is related to it. Catheter can break. Catheter can become, there is an adhesion of catheter between the wall, and it becomes difficult to take out. So this was the procedure. If you have any questions, no need of clapping. If you have any question, you can do it. And after the next presentation, there are 2 more presentations. Then we will show you on the mannequin how to do it.
Now I invite Dr. Junaid Muhib Khan. He's American Board Certified in Pediatrics and Neonatal Perinatal Medicine and American Board in Medical Quality. Currently, he is working as Director of Medical Education, Senior Consultant Neonatologist, and Associate Director of Residency Program in SSMC, Mayo, UAE, and USA. He is visiting faculty in Pakistan and Canada. He will talk about prevention of central line associated bloodstream infections.
So thank you very much, Irfan, and thank you, Javaria. Let's wait for this thing. There are 2-3 things I have to be discussed with Dr. Irfan. Dr. Irfan said about the catheter cut, but maybe there is some type of catheter you can cut, but be careful because it is become sharp. So it is better not to cut, but be careful that. Second thing, the site of insertion of the catheter, it should be visible. The third thing, now it's not recommended to send the tip of catheter if you have an infection. So please don't do it because it can do the false positive results. So let's say, what is the evidence base? How to prevent the CLABSI? CLABSI is the central line associated bloodstream infection. Okay, I have nothing to disclose. This screen is not working. This screen. So my objectives as described about the CLABSI, how to prevent it, and some frequent asked questions, because you people are not asking questions. So we will do the frequent asked questions also. This is the data from many of the developed countries, but this is the specifically the US based data. And as you can see, 296 million to 2.3 billion is the budget for spending on the infections of central line. We cannot afford that. So we are going to discuss what we can do here in Pakistan with our resources. I never use the word that we have a limited resources. You are our resources, and we have everything what we can do. So healthcare associated infection are a significant threat to the patient, and we have to avoid it. This is the old study, like 10 years old, and it's a mortality associated with BSI, bloodstream infection due to the central line, and we all know about it. The battery is dying, but as anyway, I try my best. Sorry. So these are the central line which Dr. Irfan talk about it. The UVC is the lowest. So if you need a line and the baby delivered, try to put the UVC. Don't wait that, oh, maybe need it or not, because this is the lowest infection rate is about 3.8. The PIC line is a little bit higher, then surgical inserted, of course, is a higher than that. So the UVC is very easy to insert, and of course, it is less infection catheter related. So what is the definition? The primary bloodstream infection, a laboratory confirmed bloodstream infection that is not secondary to an infection at another body site. This is the definition of central line associated infection. The secondary BSI is the BSI that is thought to be seeded from site-specific infection. How you calculate it is the CLABSI rate, is the number of the CLABSIs, okay, or the days divided by the number of the central line days multiplied by the 1,000. The utilization rate, the device utilization rate, you can calculate it by number of central line days divided by the number of patient days. If you are using the central line, you have to have a quality project on that, which we call performance improvement project. And you can all have this data. So positive blood culture, what you will do, it is healthcare associated or catheter associated, and then go according to your thing, and then specify or define whether it is a catheter related primary or the secondary infection. So the operational definitions we know, the type of the central lines we know. Now, the pathophysiology, you saw this diagram many times, but the pathogen, but they modified it in 2022, and they put the percentage. So let's say the critically ill patient, 2 to 4 vascular access devices, if it is there, the catheter, the dressing. So skin is the most important thing which can lead to the infection, which is 70–90%. Okay. Then hub and the lines is 10 to 50%, and the hematogenous is only 3 to 10%. So the mostly is your sterile techniques. Okay. If you are doing aseptic techniques, you can do it. And infusate is less than 3%. Now, what is the modifiable risk factor? That's I am talking that what we can do. Insertion circumstances, just clean it, as Dr. Irfan said to you. Skill of inserter. So these type of workshop is very helpful. You take a command on it, and it will reduce the chance of infection, insertion site, skin antisepsis, catheter lumens, duration of the catheter, and the barrier precautions. Emergency risk factor hierarchy. If you put in an emergency, of course, it is a higher chance of infection. You have to have a specified indication for that. As Irfan said, the prematurity is not the indication of central line. Then which site you are doing it, which does not make a difference, what kind of antisepsis you are using it, and so on and so forth. So these are all modifiable risk factors. Then you all heard the called the bundles. What is the bundle? Bundle is the constellations of the procedures you can do to avoid something. So if you're doing, let's say, one thing, but if you do 4 or 5 things together, the chances of having infection or the outcome is good is much higher. So we have a different kind of a bundle: central line insertion bundle, IVH reducing bundle, catheter related infection reducing bundle, and all those things. So the grouping of the practices. So these are the practices: hand hygiene, hand hygiene, hand hygiene, maximal sterile barrier, chlorhexidine, I will talk about it, optimal site care, education as we are doing right now, catheter removal as soon as possible, and monitoring of the practice, and the leadership. Leadership should involve in that. Without their accountability, it cannot be avoided. So we have a different kind of a checklist I will give you in the end, so you can use it. I will give this talk to the organizer so you can have it. So we have a different kind of a bundle before the procedure, after the procedures, and this is the central catheter bundle, daily documentation of catheter need. So let's say the baby born, and initially you think the baby don't need it, but he develops something. So then you have to know daily that when the baby need that catheter, daily review of the dressing, change dressing only weekly. We do not change the dressing unless and until it's soiled. So that's why we have to be very careful in handling those lines. Sterile gloves always, maintain closed system for the medication. Now the closed system is available everywhere. Connect infusion tubing using sterile technique. Scrub or rub the hub by this alcohol or the chlorhexidine. Surveillance activities of critical processes, and perform investigation and analysis of each CLABSI. So that's what I'm saying. If we have a central line infection of any cause, we go and investigate it. So these are the effect of hand hygiene. I don't have to go through it. It is from 1982. Most of you not born, only me and Irfan born at that time. So it is from that time up till now, the hand hygiene is the perfect way to do it. This is the adult ICU. This is actually from the Mayo Rochester, which we are affiliated, and it is for the adult line. So as you can see here, that you have to make this window, and it is so looks nice with a drape, and then you put your catheter in. Now, effect of maximal barrier. So it is 2011 again. Say the precaution and no precaution. The precaution and no precaution, it increase the infection, total infection, whether significantly, which is statistically significant. So we have to do that. Now, the education-based prevention, that if you have a regular symposium workshop like this, it is effective. Yes, it is also effective because it increased their skill and the education about it. So infection control, 1 hour about hand hygiene, isolation, handling of the patient, 1 hour training stations, and vascular guidelines. We have to have a robust standardized guideline. So it will not that if I come into unit, I put in a other way. When Irfan comes to the unit, he's trying to put another way. So we both have to be on the same page. This is not a political thing, the same page thing. So please, this is something else I am saying about. So look at this education base. After the first course and the second course, the primary BSI almost reduced to the half. So this is the reason that we have to continue these type of the workshop as we are doing right now. And this is the very latest data from the 2019. Okay, sorry about that. Now, something we have to know about it, impact of dedicated IV device care team. I know we are have a limited staff. We cannot do that. In where I am working, we have a dedicated staff, but it has its impact. If you have a dedicated staff, then really it's a good thing. But if you don't have that much staff, that's fine. Then assign somebody who can do for you. Another thing which is very cheap and is available, and I think is available in Pakistan, is a biopatch dressing. It is from the Toronto, Canada. It's saying that if you use that patch at the site, as you can see, let me have the pointer here. It's just this patch. It can reduce the infection by statistically significant. So from 29.3 to 6.1. We are not using it. Sometimes we use it if we are highly suspicious of infection, but otherwise it is very cheap, and you can use it if it is available. So this is the point. Now, there's a concept about the vancomycin flush with this thing. It is the old concept. It will not affect anything. So don't waste your money or antibiotic dose about that. So conclusion is use of vancomycin lock in high risk patient with long term is reduces the risk of the BSI is not really the thing. I don't know why it's not going. Can you just change the slide? Okay. Now, the meta-analysis of antiseptic catheter. Yes, antiseptic catheter is available. It's a sterile catheter, and of course, it is reduce the CLABSI, and it is the same catheters. It is not any special catheters. Now, the impact of the coated catheter, these are the specialized catheters, and it's a little bit expensive, but it can reduce, yes, the meta-analysis published in 2020, the 18 colonization and 16 bloodstream infection, it can reduce, the number need to treat at 8, and 55, it can reduce by 20%, 30%. But I think if you are doing a proper antiseptic technique and the hand hygiene, you don't need these specialized these things. Now the strategies, I will go through quickly. First thing, independent risk of factors for CLABSIs, prolonged hospitalization before catheterization, prolonged duration of catheterization. If the baby has a neutropenia, prematurity is also a risk itself, total parenteral nutrition. So if you are doing early feeding, you don't need a prolonged TPN. If you do early out of the ventilation or using the non-invasive ventilation, most probably the baby. And if you use breast milk and breast milk and breast milk, then of course the baby don't need a central line for that. Infrastructure, we all talk about, you have to have a laboratory, you have to have infection prevention and control program, as most of us we have. Practical implementations, the educate physician and educate healthcare personnel. This is must for that. Now, before insertion, and I'll give you these, the recommendations. The educate healthcare person is the recommendation is very high. The level of evidence is 3. Periodically assesses the knowledge. So we have the what you call the assessment of our specialists who are putting the lines, that we give him a mannequin and we see how they are doing it. And we are making a video. Again, this is not the political thing that we are making the videos of judges, but because of our training purposes. So we have to do that. So sometimes making a video is for the good purpose. Ensure that who will insert a CBC and undergo a credentialing process. So we cannot privilege everybody unless he go to the credentials. At insertion, catheter checklist, I will show you. We have to have perform hand hygiene, all-inclusive catheter card or kit. You don't have to do these type of things, but as Dr. Irfan said, some simple what you call tray, antiseptic tray, it is more than enough. Maximum barrier precautions and use chlorhexidine. Disinfect catheter hubs, needleless connectors and injection ports, remove non-essential catheters, perform surveillance, and use antimicrobial ointments only for the hemodialysis catheter insertion. So if we are doing the dialysis, we do the peritoneal dialysis and hemodialysis in our unit because we are level 4 unit. So we use the ointment that is only again and again, is only for the hemodialysis catheters, not for the routine catheters. Do not use antimicrobial prophylaxis. Do not routinely replace the CVC or catheter arterial. So previously we think that if the more than 15 days, then remove the catheter and put another line. No, if the line is working nicely, no redness, no phlebitis, you continue with that, but try not to prolong the long line, and do not routinely use positive pressure needleless connectors. So accountability, I already told you about. Now, I will go through very quickly these questions so you understand all this. Does the use of non-sterile gloves after hand hygiene compare with the hand hygiene alone prevent CLABSI in an ICU patient? So what do you think about that? That if you use the non-sterile gloves after the hand hygiene, compare with the hand hygiene alone, prevent CLABSI in an ICU patient? So let's say you are handling a line, you have a hand hygiene, and then you put any gloves. So what do you think? Is any recommendation on that? It is not the insertion I'm taking. After the insertion, when you're handling the line, giving the antibiotics, giving something. So at the point, these are actually just from the CDC, just published in April 2022. The use of non-sterile gloves after hand hygiene, but before all patient contact, compare with hand hygiene alone, is no recommendation. It's remain an unresolved issue. So what we are doing, I can tell you that we do the hand hygiene and we put unsterile gloves also on top of that. Our nurses are putting that before they handle the line. So the key question 2 is, does the use of one central line catheter type compare with the another one prevented? So as I said, that choose the central line type, the umbilical venous peripherally inserted tunnel catheter based on the clinical needs. There is no difference. Okay, so whatever the catheter type you use is up to you, but do it in a proper fashion. The recommendation 2 is the choice of central line type to insert in a neonatal intensive care patient should not be based solely on the central line associated bloodstream infection. So the choice, it's not that you want to prevent the CLABSI. What the baby needs, you have to do it, and whatever the type you have it, some types are available here. You can see after this, and then you can do it. Does the use of one central line catheter insertion site compared with another prevented? So what do you think? Irfan showed the brachial or the saphenous. So again, it depends on the need of the patient. So the choose of the need. So as I said, the UVC and UAC, if you think that this baby need a central line later on, the UVC and the UAC is the best. Okay, do not wait for this thing. But if you think that the baby, so for example, in our unit, less than 28 weeks, we are only putting the UAC. 28 weeks and above, we put the peripheral line. We start the antibiotic, the feeding right away at day 1. And most of the time, we do not need a central line. I must say, I'm very proud of it, that last 2.5 years now, we have a 0 central line infection. And this is not only because that this is the very rich countries and this and that. This is because the people working there, they are doing the hand hygiene and antiseptic technique. The 4th question, does the use of single lumen compared with the double lumen umbilical venous catheter prevent the infection? So what do you think? Of course, single lumen is better than the double lumen. But if you need a double lumen, you need a double lumen. You cannot do that. Again, as much as complication reduce in the central line, the simple the central line, the better the outcome. So consider choosing the few number of the lumen. But let's say if we have to put the double lumen, what we can do? We have to. An NICU patient requiring skin antisepsis. So this is the debatable thing, that chlorhexidine. Yes, now the chlorhexidine is recommended and it is evidence-based as compared to the alcohol or iodine. So consider the use of alcohol containing chlorhexidine is much higher than, but of course, if you have a very small baby, then use less than 2% aqueous solution as compared to the 2%. Otherwise, bigger baby, you can use chlorhexidine 2%. In NICU patient with central line catheter, does the use of central line antimicrobial locks compared with the standard of care prevent central line infection? Yes, I mean, the locks which Irfan also told about, that if you have a antimicrobial locks, then it can prevent sometimes the infection. What is the optimal duration of umbilical lines? So how many days you are putting the umbilical lines? Any duration you have, or you just put it? Minimize the duration as much as possible. When we put the arterial line, we will never go beyond 3 days. I don't need a gases that much. I don't need the blood work that much. All is in the monitor, okay? If you need the carbon dioxide, just put a capnometer, which is available everywhere, and see how much is the carbon dioxide. So we are putting umbilical arterial catheter not more than 3 days, but up to 7 days you can go. The venous catheters you can prolong for 2 weeks or more. So it depends on your unit practice. So this is the same, is associated. What is the efficacy of prophylactic anticoagulant? So this is the old theory. Before they are giving the anticoagulants also, but now we are not using the as a standard of practice, and we don't use the prophylactic anticoagulants. Which NICU patients are likely to benefit from use of chlorhexidine? And these are the things which I'm talking about. I know it's a busy slide, but as I said, we will give this thing. So for infant more than 8 weeks of age or older, 2%. For infant less than 8 weeks of age, the author clinical experience shows that the product may be used safely. But if less than 28 weeks, you be careful and try to use less than 2% of chlorhexidine. This is our central line insertion documentation. At the time of the insertion, you put all these things, just a checklist. It's a very easy to fill. You can develop like this, or you can have your own, but you have to have it. And then prep the procedure, and everything is written there. Then during the insertion, what is going on, and after that, the nurse with you and yourself, you put a note and sign this. Then after this, for our nursing staff, we have another maintenance checklist, that type of line, number of days, date dressing change, clean or dry, any sign of local infection, smart side date, and these are Sunday, Monday, Tuesday, and every day the nurse should do this checklist. So by doing this, all this bundle, you are in a safer environment. This is my last slide. You have to have, as I said in the beginning, as a PI project. How to develop a PI project? PI means performance improvement project. What we are trying to accomplish, this is the question, how we will know that a change is an improvement, and what change can we make will result in improvement. So what we're trying to accomplish in this case, trying to reduce the CLABSI. How will we know that a change is an improvement? Collect the data and study and analyze it. And this improve it, then again, do it again, that you are, how much is the rate. So definitely by doing these type of projects, I will give you an example that IVH, we reduced very significantly. The numbers is not top of my mind. Last neo-colloquium, I presented that data. By putting the IVH bundle, we just reduced tremendously IVH in our very, very small babies. That's all I have to say. And during the workshop, we will be here, and then we can answer your questions. So thanks a lot for your attention.
Thank you, sir. Now I request Professor Abid Ali Qureshi Professor of Pediatric Radiology, Head of Radiology Department at University of Child Health Sciences, Children's Hospital, Lahore. He is Fellow and Examiner of College of Physicians and Surgeons, a renowned academic personality with outstanding contributions in uplifting the department. He will share with us the use of ultrasonography in insertion of central line.
Thank you, Professor Dr. Irfan and the rest of the organizers. Our main objective regarding the use of ultrasound for the use of vascular access during the venipuncture or vascular puncture, and then localization of catheters. Our main objective is to tell you the basic knobology of the ultrasound machine. When we talk about the knobology, means different modes of its use, like B mode, difference between B mode, M mode, color Doppler, and spectral Doppler images, just to have its proper use. And the second thing is the selection of probes. There is variety of probes available with the ultrasound, and what is the best probe to see the vascular, to guide the vascular access and to localize the tip of the needle. And the third point is the exact how to identify the cross-sectional image of a needle tip and a catheter using the ultrasound. So for further elaboration, I will request Dr. Ahmed Imran, Assistant Professor of Pediatric Radiology, just to give you the brief idea regarding the use of ultrasound for the vascular access. Dr. Ahmed Imran.
Good evening all, and thank you so much, sir. So as the sir has elaborated that we'll be more concerned and more in line with the use of ultrasound machine. Obviously, our main objective will be to guide you how to look a needle or track a needle on ultrasound. But before embarking upon an ultrasound guide needle localization, we must appreciate how a machine works and what are the basic parameters to look for a good ultrasound image. ये slides आगे move कीजिएगा. So there are two aspects of learning in an ultrasound. First aspect is your cognitive skill, and then the second aspect is your technical skill. When we talk about the cognitive skills, these are the actual knowledge of some aspects, and particular and main aspect is the ultrasound machine, how it works. Then the infection control standards for cases of central venous line insertions based upon the ultrasound machine के उसके साथ आप किस तरह handle करेंगे infection control को. Then the surface anatomy from your basic knowledge, localization and patency on ultrasound, how to localize and how to determine the vessel is patent, and atypical anatomy and color flow spectral pattern. These are the basic concepts which or the knowledge you should have prior to the localization. After that, we'll come upon how to operate and to guide and to see the needle on our desired path. Then the use of needle guides and coordination of the needle insertion with imaging. आहिस्ता आहिस्ता मैं आपको सारा इसके बारे में बताता हूँ. And then after confirmation of the vessels कि हम जब catheter place कर लिया, how to localize the tip. When we talk about the ultrasound machine, there are recent advances day by day by which there are new techniques and new standards, new equipments and new probes which are coming, and we should make ourselves familiar with these things. So मैं भी आपको सारा guide करता हूँ किस तरह आपने exact machine और exact probe को select करना है for central venous line insertions. There are traditionally two techniques. One is the freehand technique जो traditionally use होती है, and the second one is the needle guidance by an ultrasound, वो हम अभी discuss करते हैं. So there are various types of ultrasound machines. You have all seen these machines in your working environment and in your setups. The first and the foremost are the ones which are highlighted on the top. These are, we label them as high-end machines or the machines which have the higher imaging quality. And then there are certain machines which are portable, just like a laptop or even on the trolleys. You can place them anywhere in your department. Selection of machine is important for any procedure. What type of machine do you want? And it's always recommended that you should have a good quality machine that should show a adequate image before you start a procedure. Nowadays, these are the ideal machines which have been shown for a vascular bedside or even in ICU settings for an ultrasound guided procedures. These are handy to carry, can be placed easily on the bedside, and are easy to manage. Certainly, there are now machines which are which can be carried in a pocket or even a small bag, just like these. These are tiny pocket-held machines, and we also label them as handheld machines. And there are machines which are now connected to the imaging display with the help of Wi-Fi as well. But these are all obviously not matching the criteria of the high-end machines जो हमने आपको शुरू में दिखाई है, और one which is displayed right here. These always recommended that vascular intervention should be carried out on a good quality machine. This is the most important aspect of any imaging procedure, image guided procedure. You should know what equipment do you have, or what type of arms do you have to fight the patient with the disease. The first is the convex probe. Most of you will have been familiar with the stuff. What is the convex probe? As the name suggests, it is convex from the top. Then there is a linear probe and multiple array of things which are available in the market. Focused on the ultrasound guided vascular approach, the linear probes are the ideal ones. Rest of the probes are not ideal. I'll show you why. So there are technical differences. We must have an insight to what are the technical differences. The first and the foremost aspect is the frequency. You need a high frequency probe for visualization of a vessel. High frequency are always the linear probes. These are also having some degree of high frequency, but the actual aspect is the visualization. As you see, the curvilinear probe has a frequency of 3.5. The technical details are quite complex, but you can just remember that the linear probes have the most higher frequency ranges. These start with the 7.5 megahertz and it goes up to 20 megahertz, or even now 22 megahertz probes are available in the market. Whereas these other probes have all low frequency other than the linear probe. So when we talk about the high frequency probes, these are always linear in head. There are many types of formations of these linear heads. There are fewer smaller in size, other are the larger, but any linear probe can make your day for the frequency, for the procedure. This is an important slide to understand why we prefer a linear probe. It just elaborates the depth of the echoes which it can transmit. You can see that the microconvex probe can transmit up to the 30 centimeter. That's the frequency. And when we talk about the wavelength, by our physics knowledge in the primary schools, we know that as the frequency will increase, wavelength will decrease. And जहाँ पे हम frequency बढ़ा रहे हैं और wavelength कम हो रही है. Now, our chance to visualize a superficial structure will improve with the linear probe. And our chance to visualize the superficial structure will decrease with the curvilinear probe. That's the basic concept in selecting a linear probe for vessel localization. Vessels are located, either you say brachiocephalic or even a central internal jugular vein, or a cephalic or basilic vein. These are superficially located veins. And if you try to localize with a curvilinear probe, it will have a poor imaging quality and a poor visualization. No doubt it can show you the area, but you can't actually or precisely go for a vessel with the help of a convex probe. This image was actually included just to show you the basic landmarks, how to hold a probe. This is a landmark which should always be displayed. Most of the times it's displayed on your every type of probes, any manufacturer, any type of quality of the machine, this mark is present, and this mark should always be directed towards yourself when you hold a probe. This is another mark which is always present on the probe, and it should be directed cranially, away from you or towards the head of the patient. With this appearance, you can easily hold a probe in an ideal manner. So this was the basic aspect of probe selection and a machine selection. After you have a good quality machine in your hands, then you should look upon an ultrasound image. How does it look like? There are many appearances on a monitor by which you can recognize कि हम किस किस्म का image देख रहे हैं. First image जो हमें नजर आता है, वो मैं उसकी ज़्यादा डिटेल में नहीं जाऊंगा, but this is the actual grayscale image. We call it grayscale because there is no color involved in it. It shows only white and gray. This is a two-dimensional image. Then there is an M mode. We'll not go into the details. It's mostly used nowadays in echocardiography. And then there is a color mode. If you just appreciate this image, that on the background of a grayscale image, we have added color on it. This is called color Doppler image. And after that color Doppler image, you can simultaneously see a color Doppler and a grayscale image on a single screen as well by selecting a few buttons and few knobology on the ultrasound machine. And with this, you can see both the types simultaneously. Then the third aspect is this spectral pattern. Most of the times in ultrasound guided interventions, we don't need this spectral image. We call it a spectral image because it shows us the spectrum. How does the flow looks like? There are two types of spectrum, either an arterial spectrum or a venous spectrum. This is an arterial spectrum which shows pulsatile image, and a venous spectrum shows a monophasic image, a simple, that can help to a beginner. Mostly radiologists can easily localize a vessel by its location. But at times, if you are confused and that we're looking at an artery or a vein, just put the color and this spectrum within, and it will show what type of vessel we are targeting at. These are all basic steps before needle insertion. So that's why this learning of these aspects is important before inserting a needle. Just to summarize what we have learned up till now, a grayscale image, put a color in it, it will show you the vessel, exact site. यहाँ पे शायद थोड़ा सा learners के लिए मुश्किल हो, where is the vessel located, and then which type of vessel it is. Routinely, prescriptions पे आप लोग advise कर रहे होते हैं duplex scan and then a triplex scan. It's just how you go about. Only one quality, two qualities, and three qualities, duplex and triplex. Otherwise, you can easily say a color Doppler or a spectral Doppler. Now we come on to the needle localization based upon our knowledge of how our vessel should be localized. There are two techniques to localize a vessel when we insert a needle. One is called as in plane and the other is called as out of plane. In this image, you can appreciate the needle is being passed along the longitudinal track of the probe. It's called in plane. And in this, the needle is passed perpendicular to the probe. जब हम इस तरह प्रोब को रखेंगे तो दोनों तरीकों से वेसल डिफरेंट ओरिएंटेशन में नजर आएगी. ये जस्ट आपको सिर्फ एक एलैबोरेट करने के लिए, इफ यू प्लेस अ नीडल एंड द प्रोब एट 90 degree angle so that the probe is horizontally oriented and the needle is going into it, it's the out of plane technique. And if the needle is going along the 180 degree axis of the perpendicular the probe, it's called in plane technique. जब आप in plane या longitudinal probe को प्लेस करेंगे on any vessel, तो vessel हमें longitudinal नजर आएगी. और जब हम horizontal प्लेस करेंगे तो vessel हमें in a cut section नजर आएगी. It's called an axial plane. In plane के अंदर आपको needle का पूरा track उसके अंदर जाता हुआ नजर आएगा, and you'll see a whole length of needle. Whereas in out of plane, you'll see just a tiny spot of needle that can be a tip of the needle, that can be a part of needle. For example, I'll just elaborate. If you're passing a needle through this track, and only the point over here will be elaborated, and if your needle tip is located outside the vessel, you'll not be able to localize the needle tip with this one. So these two techniques actually augment each other while localization of vessel. You can't say that I can do it only with one technique. Both of the techniques at the same time in a single procedure can be used. And it also depends upon the ability or the technical capability of the operator. So again, a demonstration, how we'll see the needle in an in plane and out of plane. Just to demonstrate that if you'll place a probe along the line of the vessel in a linear manner, you'll see the whole of the needle track coming into the vessel. And it's a more accurate, I personally prefer this one because you see the whole track and you can see the needle coming into it. Or the other ways, you just see it. And now there are some advantages and disadvantages of each technique. For example, if you'll go with an out of plane, you are just concentrating your plane or your view to this vessel. You are not able to see any other vessel lying beside it. Just like in this view, next one जो हम देख रहे थे, there is another vessel into it. हमें in plane view के अंदर ये दूसरी vessel नजर नहीं आ रही. Same object है, same thing है, but दूसरी vessel नजर नहीं आएगी because in this plane you are targeting your probe to this vessel only. The vessel lying outside this plane will not be visible. So for better anatomical evaluation, out of plane view is always helpful. So they just a summary of the advantages and disadvantages of two. In plane, you'll see the entire length, whereas in out of plane, you just see the needle tip. Whereas in plane में आपको anatomy कम नजर आएगी and it will see the anatomy much better. So कहने कोई बहुत आसान है. You'll just place the probe on the vessel, but you should know the anatomy. You should know the machine handling, probe handling. You should know how to make yourself comfortable with the machine and then put the needle. After that, you'll be easily able to see where the needle is going. But if you're not able to manage yourself on the machine or the probe, then the needle will not be visible at all. So जो aspects मैंने आपको शुरू में बताया कि high frequency probe को select करना, probe और machine की selection और उसकी orientation को समझना, वो सबसे important है. Needle और vessels को देखना उसके बाद आसान हो जाता है. ठीक है, सो विल ट्राई. आपको अभी हम डेमोन्स्ट्रेशन भी दे देते हैं कि मोस्टली आप लोगों ने अल्ट्रासाउंड मशीन्स देखी होंगी. सो उसके बाद हम फिर आपको एक दफा डेमोन्स्ट्रेशन भी देते हैं. एनीवन इज वेलकम टू आस्क एनी क्वेश्चंस. थैंक यू.
Now there will be demonstration of central line insertion by Dr. Muhammad Usman Khalid, Senior Registrar Neonatology at University of Child and Sciences Children Hospital Lahore, and Charge Nurse Ms. Sonia Anwar. This will be and the radiology team. And this session will be followed by a hands-on session by the participants.
And make
Ji, Assalamualaikum. We are about to begin the demonstration for PICC line insertion. Whenever we start PICC line insertion, first we are supposed to prepare ourselves, prepare the baby, and prepare our equipments. To prepare ourselves, first we'll wash our hands. Then, after washing our hands, we'll prepare the equipment and the baby. We will attach baby with the cardiac monitor, and we will give analgesic, oral analgesic sucrose solution, as Professor Irfan Waheed mentioned, to relieve the pain of that baby. That will be just pain of that needle prick. Our equipment has already been prepared. Now, we'll put on our mask and put on our cap. Now, we are about to measure the desired length of insertion from the site of prick to the depth of insertion. That is, the Professor Irfan Waheed has mentioned already, like that is the junction of superior vena cava or inferior vena cava with the right atrium. And our sister is going to demonstrate. We are going to use the basilic vein. We are going to use the basilic vein. And we will place it to the course of the vein to the sternoclavicular joint of the same side, then downwards till the third intercostal space. So our desired length of insertion is 12 centimeters. Now, we will show
Okay, so when you're putting the gown, make sure that you not touch the front of it. Okay, it is very important. And what our nurse did, you cannot do that. That to pull your sleeves up. ये जो sleeves है ना, ये ऊपर नहीं खींचनी आपको अपने हाथों से. मैंने अक्सर ये देखा है, मतलब जब गाउन पहनते हैं कि वो स्लीव्स ऊपर कर ली अपने. That's wrong. Okay, so just keep it like that, keep it that, then you put the gloves. So how you put the gloves, you can see it. Yeah, you have to use the insides of that because both gloves are fine. sister are a little bit anxious, so don't worry about that. So we are doing very good. Okay. Yeah. Why you are putting 2 gloves?
We are about to put 2 gloves as we are supposed to clear with pyodine the site of insertion. And once we are about to clear the site of insertion with pyodine, or the first layer of our glove will be just a little bit infectious, then we are supposed to remove
Yeah.
that first layer.
So you don't have chlorhexidine in your unit. It's not available.
Well, we use pyodine or alcohol.
Okay. So as I said that if you have chlorhexidine, use chlorhexidine. If you don't have, then use iodine. Okay.
Now we are about to get 2 sterile sheets. Now we are about to get sterile sheets with the central aperture to prepare the site of insertion. There is a central hole in aperture in it, and we are about to place that sheet in a way that the face of baby must be exposed to you, so that you may experience any color change or breathing of the baby.
So in addition to that, never cover the face of the baby, whatever the reason it is. Okay. The babies are nose breather. So never cover the nose of the baby. Okay.
Now we are about to clear the site of insertion with the solution, with antiseptic solution. We'll hold the gauze paste with the sponge holding forceps, and then dip it in a little bit of pyodine and clear the site of insertion from center to outwards. Now we are about to clean that applied pyodine. No.
Okay. One thing I have to add on this, that when you apply pyodine, you apply it, okay, then wait for a while until it dry, because if you clean it, it will not have all the effects. Okay. So remember that if you don't clean it right away, just wait until it dry, then it is. Maybe Khalil, you are doing the same thing, huh?
Yeah.
Yeah, you are not cleaning it, huh? Okay.
That's perfect. Now we'll just remove the first layer of our gloves, which have already been a bit contaminated. First layer of glove. Apply the tourniquet.
All of you can see the site, huh? The insertion site. That's very good.
tourniquet has to be applied just distal to the site of insertion. Now, now we are just supposed to draw the catheter, and we are about to prime that catheter with heparinized solution.
So as you can see, you have to flush the line. It's not only to heparize, but to remove the air. Because if the air goes in, the patient goes out. So don't do that. Okay. So you have to flush the line.
Now we are ready for the prick. Now we will just prick the desired site.
Just to tell you, give me this. It's okay, you are sterile, but anyway, this is the needle which is breakable. What Irfan showed is some cannula, it is a plastic thing which is breakable. Whatever you have, the technique is the same. Okay.
So we are about to prick the identified site. We will prick, that will be just fine single prick, and will observe some blood coming out of the inserted cannula. As soon as we see the blood coming out of the cannula, we will loosen the tourniquet and start inserting our catheter with the target desired length. Well, while insertion, we can advance our catheter with non-tooth forceps. That tooth forceps may damage that catheter. That is very delicate. So we'll use non-tooth forceps and gradually advance that catheter to the desired length of insertion that we have already measured. Once the desired length of insertion has been achieved, we will just break that needle. This is a needle that can be break, and we have just squeezed the two feathers of that needle, and that just break away.
The two things. Yeah, first you can first you can pull out the needle and press the insertion side, as Irfan told you, to not to pull the line back. Okay, and then you can break the needle very carefully, because sometimes it can pull the line. So that's why Dr. Irfan said that put always 1 cm, 2 cm extra in it, because during this procedure, it might have big possibility that it come down. So you see this needle, you can put it here, I can show that. So as you can see, this needle is now break down, so it's easily come out. Okay. Camera. You can see. Yeah, this is the breakaway needle. Okay. So either you can have this type of needle or the other type, which can be the cannula, you can break it, which is the plastic. Then after doing this, then you have to cover this thing. Is there strip name?
So we'll
just 1 minute. I have. So at this point, can you focus here? At this point, when you put it this thing, remember Dr. Irfan talk, you have to put a steady strip here and leave the baby until you confirm the position. Okay. So this is very important. So we don't have the stereo script, so just think that this is the stereo script. So we would put it like this and leave it until the radiologist come. I mean, not the radiologist, the technician come and do the X-ray for us, and we can see, confirm the position, and then do the dressing. Okay, go ahead.
When we have confirmed the position, that is just at the tip of right atrium, at the junction of right superior vena cava and the right atrium, then we will just plan to secure it as a final secure.
So let me ask you one question. Let's say the big line is here in the subclavian region. What you will do? Anybody? It's not at the junction of atrium and supravena cava or inferior and the atrium. So what you will do? Anybody? Yes, ma'am. I always say ma'am. Huh? Okay. Go ahead, go ahead. Ji,
We
farmaiye.
always insert 1 to 2 centimeter more so that we do not have to push it. We cannot push the line, but we can pull it out of the vein.
Why you pull it out?
हम pull कर सकते हैं, पर अगर हम push करेंगे तो infection जाएगा.
नहीं तो pull क्यों कर रही हैं?
1 to 2 centimeter extra हम डालते हैं, फिर अपनी location.
नहीं, अगर first करें, the line is on subclavian here. So what you will do?
नहीं करनी पड़ेगी.
कुछ नहीं करें. Just leave it. Subclavian is a big vein. Okay. Just leave it. Don't try to put another line on this thing. It is a long line. Okay. You can say, or you can say that this cannot be the central one, but it is the long line. So after this, yes, sir. Yeah. So this is the thing. Any position, let's say you put in the saphenous, it goes up to the higher part of the saphenous, and for some reason you cannot proceed, but do not try to remove it or pull it. If it is flushing very nicely, just leave it alone. It will last at least 2-3 weeks. Irfan has something to say.
I just wanted to say a very nicely coiled long line. But you know, by the rules of physics, longer a tube is, any tube, more the pressure that you will require to push the fluid through. You have to see the manufacturer's recommendations about cutting the tube. This one was, which one was there? Premic 2FR, neutral line. How long? Sonia, how long was that? So 20 centimeter. And what was the length from site of insertion to the 12? So if it is a 12 centimeter that you have to put in, try putting in 14.
Yeah, exactly.
Because then you can withdraw. But once, but once you have achieved this position and you see that it is in subclavian, like Dr. Junaid said, you cannot then push. आप अब यूं नहीं कर सकते अंदर push. वो needle के through ही push कर सकते हैं. अब 14 का advantage ये है कि if it is a little bit in the heart, then you can just pull it out, same centimeter, and then fix it. One, this is a 20 centimeter long. मैं इसको निकाल लेता हूँ. So if I think the polyurethane, they recommend that you can cut it. So if this is 20 centimeter, how much would you cut to make it, let's say 14 centimeter? कितना काटेंगे? 20 में से 6 काटेंगे. So 6 काट के front के ऊपर से आपने notes में you have to mention it in the notes that you have cut 6 centimeter, and then you can thread it. Or some of the manufacturers, this is a butterfly. They have a special receptacle for butterfly, which is on one side is sticking, and you can just put like this, कड़क करके वो उसके अंदर, वो इस जगह के ऊपर यूं आप कड़क करके उसको फिक्स करते हैं इसके साथ ना. You can do it. So मुख्तलिफ चीजें आती हैं fixation के लिए. So the point is, if you cut it in this scenario, cut it at 6 centimeter and put it in the notes, that rest is 14. So that at the end, after a week or 10 days, when I take it out, I will see that it is 14 centimeter. It has to be 14 centimeter. But there are certain other these long lines, especially of silicone. नहीं ये भी प्रेमी वही है. Silicone वो epicutaneous करके जो आती है. that's made of silicon, you cannot cut it because the manufacturers does not recommend it. It has certain special type of metal inside it, you can't cut it. So this one you can cut, but you have to mention it.
The other thing is that when you're removing it very carefully, because if a part of the line remain inside, it happened, the line can be broken. It's a big thing. Then you have to call the pediatric vascular surgeon. He has to do the dissection and has to remove it. There is no other way that you can remove that part. So, and of course, it is a big harbor for the infection. So now we will complete our dressing. Sister, you can do it, our dressing.
Needle-less connector.
This is the one which we are.
This one needle-less connector. It's very easy to clean. बस वो हम रखते हैं अपने हाथ पे शक्ल के ध्यान से आ जाएगा कैमरा का नहीं yeah. So this is a needle-less connector and you see that this is an open hub. If you just put it like this, now it is sealed. You don't have to open it again and again. You just, if you see the tip, it's flat. It has got a special spring inside and syringe. You just clean it and this is a lure lock. You can put up a syringe straight away. And if you remove it just like this, it's not going to bleed blood. So this is an advantage of this needle-less connector. Achha. So this is a three-way, I won't open it. This is a three-line octopus. This is a single line with needle-less connectors. You can get it without needle-less connectors also. So all these are used for infection prevention. Germs cannot enter this port. But if it is like this, yes, they can enter. Achha. ये भी हमने इसका फिक्सेशन है बताओ उसके ऊपर वाला है बड़ा वाला नहीं बड़े वाला नहीं नहीं नो नॉट चेरी स्ट्रिप वो कैनल ड्रेसिंग जो होती है जैसे हाँ पहले चलो कैनल ड्रेसिंग देते हैं. If you have that butterfly thing, you will just put it like this, and it is better to leave the entry site where you can see it. But in the other type of cannula, which is silicone, where there is a hub, then because the hub is a bit thicker and coarse, then you put it like this and cover it with this. Once you do it with your own hands, you so let's say this is like this. Sonia, can you put it? You don't even need any gauze because there is no hub.
Just a one transparent dressing is good enough. You can see the entry side of the line. The only thing is that जो भी handlers हैं उनको मैं ये कहता हूँ कि लाइन से पकड़ के झूला नहीं झूलना बस वो लाइन से पकड़ के बच्चे को भी नहीं उठाना. So because it can move, if the line moves up and down inside the body of the baby, it will increase the chances of infection. So it has to be secure very nicely. Huh? Yeah, it's as she did, is a very nice now clean line. You can see there covered. Yeah.
इसने एंट्री पॉइंट पे कवर कर ली सारा और इसने इसको पूरा एनसर्कल नहीं किया बाजू को के ऐसे वो उसको उतार एक जगह खुली जरूर रहनी चाहिए और the indications are there to take it out. Just one side I don't know, just peel it like this. Now comes the entry point. Put up let's say okay, this is a gauze piece here and take it out, gently just drag it out, gently drag it out, gently. If it gets stuck, push a little bit of fluid, warm the other extremity, these, and then just gradually pull it out with this non-tooth forceps till it comes out. Previously, it used to be that you would send the tip for culture, but it is not done currently anymore. And after, just keep your hand here for a little while, 2-3 minutes. When it stops, you can even put up a single stereo. What's that called? वो जो चोट पे लगाते हैं? Saniplast. That's all.
Yeah.
Nothing else.
Nothing
And
else.
just leave it.
Yeah.
Pitch hit करें उसे तगड़ा.
Okay, that's
And
the
this
thing.
is it.
So any questions? Please, this is the time you can ask questions. Anybody, have any questions?
We need to.
Yeah,
demonstration.
it will come there. So I'm just asking, come, you can start.
Locate the tip. Either you use an X-ray, but the better thing is to use an ultrasound, and Dr. Ahmed will demonstrate how we can see the tip of needle. Karo?
Chalo. You can see this is green. On the screen.
बेटा आपने इसको फोकस कर दो इस पे आइए नीचे.
So here, Professor Abid Saab and Dr. Ahmed will demonstrate you how to assess
ये panel
PICC
fix
line with
कीजिएगा.
ultrasound.
ठीक है. इस
So right now we are looking at the main protein nobology of the machine. देखने में कॉम्प्लेक्स लगती है. कुछ 2 या 3 चीजें जो आपको हर वक्त पता होनी चाहिए. एक इसमें ये फ्रीज का बटन होता है और इस पे हमेशा मेंशन्ड होता है फ्रीज. विद दिस फ्रीज यू कैन मेक योर प्रोब. अभी इस वक्त इसको मैंने अनफ्रीज किया था. यू कैन सी ओवर द स्क्रीन दैट द इमेज इज देयर. And when I'll freeze this one, उसके बाद ये unfreeze करना पड़ेगा to see the image. Whenever you're not using the machine, it's always mandatory that you freeze this, and when you're using it, that unfreeze it. उसके बाद अगर आप यहाँ पे nobology में देखिएगा, दोबारा बेटा इसको focus कीजिए. There is a knob which says 2D. इसको बेटा थोड़ा सा आगे लाके आप कीजिएगा तो आपको नजर आ जाएगा इस पे 2D लिखा हुआ है. This is the one which I've told you, the grayscale, the 2-dimensional image, which will show you only the gray and white color. Then there is a probe which is saying CDI, that's color Doppler imaging. With this, you can enter, and this color Doppler appearance will appear on this. If you're looking at a vessel, उसमें color नजर आना शुरू हो जाएगा, जो कि इस तरह इस box के अंदर होगा. Wherever you'll place this box will show the color. And after that, there is another button which says CW or PW. You can choose any one of them. That's quite synonymous with each other. That's the spectral pattern. And when you place this one, the spectrum will appear underlying the color image on the screen. So this is the triphasic or triplex image, in which you are using a grayscale on right side, then a color Doppler on this side, and a spectrum on this side. Most of the times when we'll do an ultrasound guided localization, a 2D image is sufficient enough to show you most of the things. Just like this, I have selected a grayscale, a linear probe with a marker on the medial aspect, जो मैंने आपको पहले show किया था. This is the marker which should be placed towards you whenever you are holding this machine or with this probe. Just like this, just like you hold a pencil, you'll hold this probe with your right hand, marker pointing towards you, and the other marker which I showed you pointing towards the head of the patient. And you'll place like this on whatever you are going to see. Now, if you'll appreciate on the screen, you'll watching a 2D image. But machine is screen पे focus कीजिए. So with this, you are watching a 2D image, and I can probe with this one. I have placed a probe. ये मुझे थोड़ा सा इसको side पे रखना पड़ेगा. अच्छा, इसमें important ये है कि whenever you are doing an ultrasound guided intervention with the help of machine, you need to handle your left hand with the probe and your right hand with the needle. If you are the left-handed person, then you can do an opposite way. आपके left hand में probe होगी. Ideally, when we do ultrasound, we do it with the right hand only. But when we are operating a needle with the help of ultrasound, the needle should be in the right hand and your probe should be in your left hand. With this, you'll just, अब इस वक्त जो मैंने probe place की हुई है, that's perpendicular on the body. I'm going in plane and you just see on the screen, but आप screen focus कीजिएगा सिर्फ. कहाँ से करते हैं? नहीं मैंने आप screen को करेंगे. जी जी. And you'll see that my needle is going inside and I'm just looking at my needle. It's coming out and then it's going in. The desired depth of my needle will depend upon कि मैं कितना deep जाऊंगा. That will be the location of the vessel. If I'll just put this one on out of plane, now you just see that I'm just seeing जो आपको mark हिलता हुआ नजर आ रहा है, सिर्फ इतना ही नजर आएगा. नीडल टिप के लिए मुझे अपने आप को मूव करना पड़ेगा. ये नीडल टिप है जो मैं मूव कर रहा हूँ. इसमें मुझे सिर्फ इतनी ही नजर आएगी. That's a needle tip. But when I'll place again in the perpendicular plane, तो जी so मुझे प्रोब पूरी लेंथ में इसमें मूव करती हुई नजर आएगी. Now if you look at this image, तो हमें प्रोब जो नीडल की अपीयरेंस है उसको अपने आप को अप्रिशिएट करना पड़ेगा कि the moving object is the needle. Most of the new ultrasound machines have needle enhancers in them. You'll just place a button on the machine and with that the machine will show you the needle track with more clarity. If you just appreciate, this is the way we can see the needle moving in and out in plane in the whole length. And if I place my probe just perpendicular to the one, then I will be just looking at the one cross-sectional point of the needle. Maybe that should not be the needle tip. So for that, you need to have an orientation of your probe and your needle कि आपकी needle tip कहाँ पड़ी हुई है. So इसमें एक important aspect जो शायद मैं पहले बताना भूल गया कि whenever we're doing an intervention with the help of ultrasound, we have made a sterile field. Nowadays, there are probe covers available which are in the form of a long sheet and they can be placed over whole length of this probe and its wire and you'll keep yourself in a sterile plane. और बहुत easily market में इस वक्त available है. उनके जरिए आप पहले अपना plane aseptic measures लें और उसके बाद just place a probe over that and you can use it at many as time. उसमें एक aspect जो बहुत ज़्यादा लोगों को confuse करता है कि when we place a probe cover तो हम gel कैसे लगाएंगे. For that you can use simple saline during the procedure or even you can use pyodine as well. Biopsy कर रहे हैं कोई और है, हम pyodine भी use कर सकते हैं या simple 10 cc syringe में saline place करके अपने पास रखिए और जब कभी आपको लगे कि आपका field dry हो रहा है, you can just spill a few milliliter mLs of saline over the field और आपको दोबारा सब कुछ नजर आ रहा होगा. So anyone who wants to do an hands-on can come and will guide. Thank you.
So any questions regarding procedure of PICC line or ultrasound? Ji.
What is the question?
Yes, doctor.
So thank you for giving us such a nice tutorial. I just want to know about the lock which is used at the end of the PICC line, which was
Yeah.
the lock. Yes.
This
वो
is
जो
the-
tip PICC के end पे जो lock था ना,
That's the one Dr. Irfan showed you before. That's you are talking about. Okay, so this is just a simple thing. The other one, green one.
Not long.
No, no, no.
Needle-less connector.
Needle-less connector, yeah, this is the one. So this is the needle-less connector. So you can connect from here and you connect your syringe. So the advantage is that it is sterile and the chances of getting infection is very, very low. If you leave, yeah.
This one is also needleless.
Yes, this one is also. This is the needle.
What is the next advantage for this extra?
No, this is not extra. This is another device. If you don't have anything, this is the two things. Yeah. Yeah. No, that's the thing. Go in. Yeah.
Connector.
And when you have this connector and removing and putting the syringes direct on the line, it can move the line. Okay, so this is much more secure.
This is a lower lock with chudi nahi hota jiska. This is with the lower lock. You can just put up a lower lock syringe over. Yeah.
Any other question?
Okay.
Anybody?
Assalamu alaikum. I'm from Liaquat National Hospital, Karachi. In our NICU, the PICC lines get blocked very easily. So how to prevent that?
Big pen line?
They get blocked very easily.
They get blocked.
Yes, beta, they get blocked easily if you don't have a trained staff. And if the staff is not trained how to use it and how to prevent clogging, it will clog. So you have to run the fluid continuously, 1 million hour minimum. In
Yeah.
some books, it is written 0.5 million hour. So it must run continuously. If you are giving TPN, if you are giving any other fluid, it must run continuously. If you are not using it, if you are now ready to take it out, then you have to haplock it.
Yes. Okay, and the other thing is that try not to give the blood and the blood products through the PICC line. Okay, because the consistency, the density is very high. So for us, it never blocked. And the reason what Irfan said, it has to be continuous flow of the fluid because this is very small lumen, as you can see that. Okay, so just
Precaution.
maintenance of that precaution.
Answer is precaution.
Yes, sir. Khalid bhai.
Just want to give one comment as they are asking about this blockade. So you are not going to push fluid into the PICC line. You have to use syringe pumps. So until unless you don't have the syringe pumps, you are not going to use it, right? So this is important. As Dr. Irfan said, you have to give 0.5 ml per kg. So you are not going to continuously give it the syringe. So you need to have syringe pumps as
Syringe
well.
pump or infusion pump.
Yeah.
For TPN, infusion pumps are used.
That is also very
So
important.
infusion has to be continuous.
Yeah, so you can't use these PICC lines without that.
About 10 years back, when we started putting up these long lines in the babies, of course, our staff wasn't that much trained at that time. So the first problem we encountered was blockage. And that was the reason when they were giving some fluid, and at the time when they were changing it to another fluid, they will stop the first fluid. They will take few minutes to prepare another fluid and attach. And during that period, it was clogged. So it has to be continuous. Any other beta? Sanjay?
सर मेरी क्वेश्चन इज रिगार्डिंग जो आपने सब बताया था कि जो टिप ऑफ बेचते हैं हम कल्चर के लिए, तो सर इसमें जैसे आपने बताया कि इट इज नॉट रिकमेंडेड कि सेंट्रल लाइन को उतनी भेजे। सर जो बाकी चीजें लाइक ईटीटी की टिप है, चेस्ट ट्यूब हम रिमूव करते हैं उसकी टिप है, तो वो तो हम रूटीनली भेज रहे होते हैं।
नहीं बेटा, ये अब रिकमेंडेशंस नहीं है उसकी।
सही है।
इसमें लॉन्ग लाइन के अंदर ब्लड सैंपल ही काफी है। ब्लड उसका
Exactly.
बहुत ज्यादा आपको है तो आप उसी लाइन से ब्लड ड्रॉ करके सैंपल के लिए भेज दें एंड देन स्टार्ट फ्लशिंग द लाइन।
So, and what you said that you are sending the chest tube?
सर चेस्ट ट्यूब है, ईटीटी जब रिमूव करते हैं उसके
No.
बाद उसकी भी टिप्स कल्चर के लिए भेज रहे
क्यों
होते
भेज
हैं।
रहा हो भाई?
सर हमारे सेटअप में पेरेंट्स जैसे सब भेजते थे फ्रीक्वेंटली सर कल्चर पॉजिटिव भी आते थे उसमें।
No, that's the thing, no, that it is not recommended. The reason is that it can falsify your results. Okay, so just send the two peripherally, as I showed. Because of the time, I am in a hurry, but you can take the presentation from organizers. That two sides, take the thing, or if you are very much this thing, take from the central line a little bit of this. That's enough. Okay, that's enough for this thing.
Okay, thank you, sir.
Thank you very much, Pacho. One more, Ancho.
So my question is,
is Portacath is more convenient than the PICC line in the children for the safety rules?
दोबारा बोलो बेटा.
Is the Portacath is
No.
more convenient?
Portacath.
Yes.
We are talking about neonatal neonatology or newborns. Portacath is not feasible. Portacath are those a bigger patient. First of all, if you put in a thing, first of all, I don't know that the size is available even for the full-term newborn of a Portacath. Portacath for the bigger, and the chances of infection is 100 times more than this thing. Okay, so it is for a higher age group. The Portacath, and the Portacath for the longer period of time.
Yes,
If you
longer
need a
period.
3 months, 6
And
months,
for the safety rules,
big line is
regarding-
not recommended for more than 3 to 4 weeks by the what you call distributors or manufacturers. So we never use the Portacath for those things. Okay, if let's say if the baby, I had the baby on ECMO, you know, the extracorporeal, and he has thing. We just put a Broviac.
Okay, Brovic is more. Thank you, sir.
Thank you, and let's proceed over to Dr. Javaria. Oh, thank you very much, Dr.
Thank you,
Abid
everyone.
Sahab, Dr.
Thank you,
Junaid Sahab,
Abid,
Usman,
and
and
thank
Dr.
you. Where is Ahmad? Thank you very much.
Sonia.
Now I request Professor Samia Naimullah to please come on the stage for souvenir distribution. Okay. I request Professor Khwaja Ahmed Irfan Waheed to receive his souvenir. Professor Abid Ali Qureshi. Thank you, sir. Now I request Dr. Junaid Muhib Khan to please come on the stage and receive his souvenir. Next, I request Dr. Ahmed Imran to please receive his souvenir. Dr. Muhammad Usman Khalid, please come on the stage and receive your souvenir. Charge nurse Miss Sonia Anwar. Dr. Javaria Younas. Now I request Professor Khwaja Irfan Waheed to present souvenir to Professor Samia Naimullah. Thank you all. Now I request our chief guest to share a few concluding remarks.
Thank you, Dr. Javaria. Beautiful souvenirs. Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most merciful, the most beneficent. First, I'd like to thank Professor Khwaja Irfan for inviting me here to share this evening with you. I would like to congratulate Professor Irfan and his team for a well-organized, excellent workshop with many innovative things. Beautiful coloring pictures by kids, really on germ-free. वो तो ऐसे लगता था कि आज के बच्चे हमारे अब सीख ही जाएंगे कि जर्म से सचमुच छुटकारा कैसे पाना है, और अभी सीख जाएंगे तो सारी उम्र ही रहेगा. Professor Irfan Waheed का मेरे साथ ताल्लुक है. I just remembered sitting over there. We met about 22 years ago when we was in a small workshop जो AIDS पे थी. बात हुई, he had made a presentation and so did I. So he told me he was in VA. So I said, Dr. Irfan, why don't you join me at RMC? And when he became the first professor of neonatology, we were all very, very happy, and I thought he did the right work. So that was the right decision that he took. Well, Professor Irfan is an enthusiastic, a very committed, a very, what should I say, hardworking person, and above all, a charismatic personality. And he has taken neonatology really a forward step. And I think he was the one who has really brought neonatology to this step today. And mashallah, we've got about 22 neonatologists who are really certified neonatologists. If I'm wrong, probably you can correct me later on. This workshop, which is New Cloconium 222, मैं देख रही थी कि ये क्या है, इन्होंने ये नाम कैसे चुना. So when I looked at an Urdu translation, it was Bolchal. And not only the Bolchal, it was really with good answers and questions and very academic, and it is. Today's day has been very successful, and I think we'll have the successful days tomorrow. The workshop really on sepsis, a very important subject, and all subjects in neonatology are. But looking at the neonatal morbidity and mortality, they have been listening from morning. 25% hai, 36% hai Pakistan mein, still very high, unfortunately. और फिर आज का जो स्पेशली प्रेजेंटेशन और आज की जो वर्कशॉप है on really inserting the central line, PICC line, is extremely important in neonatal units. The way it has been done, the lecture that was given by Professor Irfan, उसे देख के लग रहा था कि हमें कुछ नहीं करना पड़ेगा और हम खुद ही सारी लाइन लगा लेंगे, हम खुद ही डाल लेंगे. It was very nicely discussed. एक point उन्होंने अच्छी तरह discuss किया कि इसको कैसे करना है, who are the kids who really need it, that's the question. क्योंकि जब थोड़े दिन है, if a baby doesn't need it, we shouldn't be putting it in. क्योंकि peripheral IVs can work, but how long the peripheral IVs can work, unfortunately. दोबारा हर तीसरे दिन blood निकलता है, हर चौथे दिन IVs लगाते हैं, unfortunately, and the risk of sepsis increases. By putting a really good line, of course, and the way it has been given, and the way the Professor Junaid, who has discussed how we have to prevent the infections, and especially the bloodstream infection, that's not one person's job. Putting a line skillfully, as it has been discussed today, and then taking care of the line is extremely important. जिसमें सिर्फ doctors नहीं, हमारा nursing staff all are very important, and who have to carry it, and then really keeping the line till we need it. वही बात हम सुबह कर रहे थे, the day we need, हमें जितनी अगर 3 days antibiotics की जरूरत है, 3 days, if we need it, no. Now, ये डर के कि अब आगे पता नहीं क्या होगा, हम लाइन निकाल देंगे तो क्या हो जाएगा. Of course, we have to take a chance and take it on time. Radiology was discussed by Professor Abid or Dr. Ahmed. The beautiful pictures of ultrasound that were given, And that was reminding me of a husband who was an ultrasound and doing Dopplers. That was nicely given. And of course, we need a radiologist when we're putting these lines in. और उसके बाद जो practical demonstration Dr. Usman और Sister Sonia ने की है, that is extremely important. Hands-on training, you really see how to do it. और फिर उसी को practice करना और उसको फिर the steps that have been told by everybody, please keep in mind. होता यह है कि हम conference attend करते हैं, हम certificate ले लेते हैं, we are very happy कि आज हमने ये कर लिया, but please to put it, to implement it the way it's done. अभी गाउन पहनने पे जब डॉक्टर जुनैद ने उनको कहा कि देखें ऐसे पहने, I remembered when I was doing my neonatology in America, जब हम ट्रेनिंग करी थी, तो the neonatologist came, it was like 5:30 और उन्होंने मुझे तरफ देखा और उन्होंने मुझे कहा get out. And I was very surprised कि क्यों मुझे उन्होंने कहा get out. And he just looked at my sleeve. My sweater was showing a little bit out of sleeve and I was turned out of the ICU. So these things are very important. सिर्फ यही नहीं कि आज हम दिखा रहे हैं तो हम उसी को आज ही follow करेंगे. Please, whenever you do it, please do it the way it has been shown to you. So in the end, I would say it's an excellent, कोशिश भी बहुत excellent है और skillfully इतना हुआ है कि मेरा ख्याल है कि हर किसी को जाके ऐसे ही करना पड़ेगा. आखिरी वक्त सिर्फ एक शेर मेरे दिमाग में आया है. दर्दे दिल के वास्ते पैदा किया इंसान को, दर्दे दिल के वास्ते पैदा किया इंसान को, वरना अतायत के लिए कुछ कम ना थे करोबियाँ, वरना अतायत के लिए कुछ कम ना थे करोबियाँ. खुदा हाफिज़.
Thank you all for joining this academic activity and hope to see you on the day 2 of Neoprochium 2022 tomorrow.